Okay, so this section is the gynecology section. Let's do this question. Um, Also, I know there's many of you here. I can't take too many questions once I finish this lecture of questions. Then we can do the questions. Otherwise, it disrupts the whole flow of things. There's 76 of you. Usually, I can't answer that many questions. Anyways, I'll try to do my best. Those of you who are typing your questions, I'll keep it to the end. Okay. A 20-year-old woman comes to the physician because of the sudden onset of cramping abdominal pain. Okay, so 20-year-old female with cramping abdominal pain for 2 days and a 2-week history of pain on sexual intercourse. Okay, so pain on intercourse. She's sexually active with 3 men. She smokes marijuana, uses cocaine, heroin, and fentanyl. She uses multiple substances whenever she can. Her last menses started 8 days ago. Current medications include oral contraceptive pills and multivitamins. Her temperature is 39 Celsius. Physical examination shows a normal cervix without discharge. Bimanual examination shows right-sided tenderness. Okay. Fullness and cervical motion tenderness. Urine pregnancy test is negative. Which of the following structure is most likely affected by this patient's current conditions? Okay, pregnancy is negative. Now, for us to answer this question, at the end of the day, all the churches are anatomical structures. So that means first we have to know what is this disease. In order to answer this question, we need to know what's the disease. So therefore, the first thing is I would like to diagnose this condition. And then once I diagnose the condition, then I want to know what this condition involves, which structures. Okay. Obviously, it's going to be female reproductive system, so there's limited structures you should be thinking about. Um, Most likely, if it's the reproductive system, I'm not going to have the male reproductive, so I'll cancel those out. I'll cancel out kidney, I'll cancel out appendix, bladder. I'll restrict it to some things. That's just it. So the examining skills. Your skills of taking examination is if you think the question is regarding female reproductive system, then just by that I'm going to cancel out for now appendix, bladder, kidney. Peritoneum I won't, because sometimes things can rupture. Vas deferens, which is a male structure. Spermatic cord is a male structure, so it leads me to fallopian tube, peritoneum, and endometrium. But again, that's what I'll do first. It doesn't mean this is correct, just the examining skill. If you're confused with this question, then at least do that. Okay, let's go ahead. So let's start this question. So this is a 20-year-old female. That's one. She has cramping abdominal pain, so she has abdominal cramps. She has abdominal cramps, acute for 2 days. She has dyspareunia. So now, those of you who don't know what's dyspareunia is pain on sexual intercourse. Dyspareunia. Okay. And then she has, she's sexually active. What else is there? She's uses a lot of substance, so she's substance abuser, cocaine, heroin, and so forth, fentanyl. She has fever. Her temperature is 39. She has right side tenderness, which means the right side of the abdomen or the abdomen pelvic areas. In addition to that, she also has cervical motion tenderness. Cervical motion tenderness. There's a lot of information. So, and then pregnancy is negative. So, okay, HCG, pregnancy test, urine or blood is negative. So, with female, you will always, whenever a female has some sort of abdominal pelvic pain, rule out pregnancy first. That's rule number one. Anytime a reproductive age female that has abdominal pelvic pain or you're suspicious of pregnancy, rule it out. Very easy test, rule it out first. Okay. Reading all of this, what do we think? By reading this, a sexually active female comes with abdominal cramp, pain on sexual intercourse, and she is polysubstance use abuser, she has fever, all of those things. Most likely something to do with, sort of like STD, something like that. But if you read the whole thing, it gives you a good impression this is pelvic inflammatory disease. Pelvic inflammatory disease. Pelvic inflammatory disease, if I were to do, it's a disease or infection of the fallopian tubes, the uterus, and the cervix. It's an ascending infection. Okay, so let me just do something here that we can. So let's say here is the uterus, uterine tubes. Okay, cervix and birth canal. And remember they have the fimbriae, so this anatomical structure will be important. And let's say here is the inside of the uterus. Okay, so we have the cervix, and let me get rid of this. So this will be the birth canal. Okay, there you go. So let's label the structure: birth canal or vagina, uterus, fallopian tubes. I'll just put tubes, fallopian tube, and these are the finger or fimbriae. Okay, so this is the female reproductive system. We're just labeling these structures, and this area, the junction between the uterus and vagina, this area is called the cervix or neck of the uterus. Cervix, that's what it means. Cervix means neck. Okay, in the opening right here will be the os, cervical os. Okay, all right. Okay, so now because infection of the reproductive system are mostly STD, say somehow bacteria is introduced into the birth canal or vagina. Okay, so that's what we're looking for. So these are usually ascending infections. Somehow bacteria, let's say this is a bacteria, this red, it is introduced into vagina or birth canal, either because it's in close proximity to the anal canal, maybe E. coli and other bacteria, but sometimes, by intercourse and other ways, bacteria can be introduced. So it can cause vaginitis, and then, so that's number one, it can cause vaginitis. Number two, cervicitis, if it keeps going up, so it's ascending infection. And then it causes infection of the uterus, endometriitis. Further, it can go into the tube. Okay, so the fallopian tube infection. This constellation of infection is called pelvic inflammatory disease because all the structures are located in the pelvis. Okay, so pelvic inflammatory disease is ascending. So when you expect tubular infection, then you should also expect cervicitis as well. Usually it's a combination of the tube and cervix. Okay, if that is the case, obviously I'm going to expect an infection like that. I'll expect a female to be young and sexually active, which we have. That's one. And if that is the case, for pelvic inflammatory disease, I will expect cervical motion tenderness, number two. Okay, I'm giving the most common ones. And then maybe fever, depending if it's acute or chronic. So when I have these three, let's include the fourth one, sexually active female. There you go. So these four symptoms, if you see them, you will always think of PID. Okay, cervical motion tenderness is very, very sensitive sign of pelvic inflammatory disease and specific. So cervical motion tenderness, you can also include in here adnexal tenderness, which is really important. Let me include here adnexa. Adnexa is the area. Adnexa is the area that where the ovaries are located, the fallopian tubes. Adnexa tenderness, which is not in this question, I'm adding that. Okay, so your goal is to understand at least four symptoms that are very commonly associated with pelvic inflammatory disease. And those symptoms are cervical motion tenderness, adnexal tenderness, fever, and dyspareunia. Okay, sometimes there's discharge, sometimes there's not. So you can include discharge as well. Let's say discharge. Okay. In addition to that, you're looking for sexually active young female. So that there you go. Sexually active young female with cervical motion tenderness and fever. I'm 100% going to think of pelvic inflammatory disease first. So the three things, let me just say it here, just to make life a little bit easier because students like these kind of uh, guidance. So I always go with a triad of things or quadrate of things or four things, three or four things that kind of help me to identify something. So I'll say young, sexually active female. That's my first thing. So that's one. I'm looking for three things. Number two, I'm looking for cervical or adnexal motion tenderness, which means when you move the cervical area or the adnexal area, you palpate it, there will be some tenderness. That's two. Okay. What's the next thing that I'm looking for? And that is fever. Okay. Now, polysubstance use, cocaine, heroin, and so forth, is associated with sexual activity anyway. So that's one and the same thing. Okay. So these three things, if you memorize this triad, you will always think of pelvic inflammatory disease. Okay. Now that we have diagnosed that this person has pelvic inflammatory disease, then we need to know one more thing for step one. It's very important. What's the number one cause? The most common cause of this is chlamydia. Chlamydia and gonorrhea. Most of the time it's co-infection. Both of them infect at the same time. So that's this next information you need to know. Even though it's not important for this question, I'm just giving additional information. And the treatment therefore should be for chlamydia. The treatment should be azithromycin or tetracycline. Okay, azithromycin. Plus for gonorrhea, you will use ceftriaxone. Just in case this question is coming. Okay, so that's the treatment. Complication of this infection is it can lead to perihepatitis, infection around the liver, perihepatitis. Remember that the fallopian tubes are open into the peritoneal cavity, so the infection can, let me change my color to red, the infection can come, look at the picture, infection can sort of drop out, the bacteria can drop out, it can cause peritonitis. Okay, so therefore complication will be perihepatitis, which again, that pain can be referred to the left shoulder, right shoulder area, depending which side. Liver is primarily on the right side, so if it is right shoulder pain, okay? And additionally, can lead to tubule ovarian abscess, which is hard to treat, and ectopic pregnancy. Chronic PID leads to ectopic pregnancy, which can lead to infertility. So these are some complications, okay, that you might be asked. Most step two, but anyways, I just mentioned it. I don't know why. But we have already diagnosed our condition. Our condition is pelvic inflammatory disease. Sometimes I get carried away, I apologize. This is our diagnosis, which means it's an infection, inflammation of the vagina, mostly cervix and fallopian tubes. Okay, so let's go in our question. Do we have any of that? So what structure is affected? Mostly appendix, no. It could be complication of it, but not really. Bladder, no. Endometrium, no. Endometritis is mostly in pregnant patients, okay? Kidneys, no. Peritoneum, possibly. Fallopian tube, yes. This is actually a definition of pelvic inflammatory disease is infection of the tubes and cervix. Those two should be always included, okay? So therefore our answer should be F. That's our answer, okay? All right, hopefully this was helpful. Maybe those of you who want me to rule out this other option, I'll rule it out, but I don't have room to write, so you have to listen for A. If it was expected to be A, if you expected the answers to be appendix, I'll be looking for right lower quadrant pain, leukocytosis, and tenderness. Three things. Okay. If I wanted to call, if I was expecting acute appendicitis, I'll be looking for three things: right lower quadrant pain, leukocytosis, maybe you can include fever and tenderness. Okay. And usually the pain starts around the umbilical area and then radiates or travels to the right lower quadrant pain. Okay, so that would be appendix, which we don't have in this case. If this was bladder, then I would be expecting UTI, right? Bladder, if this was bladder, I'll be expecting UTI. For UTI, what am I expecting when it's bladder infection? Burning sensation on urination, frequency, hesitancy, rarely fever. Okay, so that's what I'll be looking for. And in women most common, right? If it was bladder. Endometrium, if this was infection of the endometrium, which is called endometriitis, I'll be expecting having a pregnant female after delivery or before delivery, suddenly developing fever, discharge, tenderness. Okay, three things: fever, discharge, tenderness. Suddenly, this will develop in a female, usually pregnant female, especially if uh, uh, the amniotic membrane are ruptured. Okay, so usually if there's some procedure done, somehow you manipulate the birth canal by introducing bacteria to that area. Okay, and the infections usually polymicrobial. We don't have that, so it's not endometrium, it's not endometriitis, so I'm going to rule that out too. Kidney, if this was kidney is also UTI, right? UTI, again, it's ascending infection. It starts in the urethra, travels to bladder, ureters, and eventually kidneys. If kidneys are involved, then it's called pyelonephritis. Pyelonephritis, what do I expect? Flank tenderness, high spiking fever with chills, and on urine analysis, I would expect cast of white blood cells. Okay, if this was pyelonephritis, which is an emergency, should be treated right away, primarily in the hospital setting. So we don't think it's kidney. Peritoneum, peritonitis. Peritonitis, if I was expecting peritonitis, that's the symptom I'm going to expect. Let me tell you: guarding, rigidity, rebound tenderness, and fever. Four things. Always think of peritonitis first: guarding, rigidity, rebound tenderness, and fever. But I don't see that in this question, so I'm not gonna. I'll rule out peritonitis. Vas deferens, remember this is a male structure. Spermatic cord is a male structure. This question is about females, so I'm not going to even talk about those. It should be easier for you to rule them out. Spermatic cord disease usually can be like testicular torsion, right? All right, let's go to the next question. Okay. Okay, so let's do this question now. Let me change my highlighter and stuff. Okay. A 55-year-old woman is brought to the emergency department by her daughter because of 10-day history of progressive shortness of breath and fatigue. Her pulse is 110 per minute, respiration is 26, blood pressure is normal, respiration is high, pulse is high, blood pressure is normal, temperature is normal, physical examination shows muffled breath sounds, pericardial knock, and friction rub. By just reading this much, you know this person's having pericarditis. Okay. Echocardiogram shows a large pericardial effusion. That's diagnostic, 100% pericarditis. Pericardiocentesis yields cloudy serosanguinous fluid, increased protein concentration, numerous RBCs, and small number of WBCs, and neoplastic cells with large nucleoli, and increased mitotic spindle fibers. Okay, which of the following site is the most likely origin of these cells? Look at that! Wow, what a question! So even though it's mostly like cardio questions, but I have it in the female reproductive system. I guess I probably had a reason. Let me just see what was the reason. Okay, so let's do first. First, let's diagnose what is this person experiencing, and then we can answer the question. The question is asking what is the origin of the neoplastic cells, cancerous cells. Okay, so let's, as usually I go, I'll repeat this information. 55-year-old female. Okay, this female has shortness of breath, progressive shortness of breath, right? Slowly progressing. And she's experiencing fatigue. Okay. Additionally, she has muffled breath sounds. Breath sounds. So she's having some lung problems, or at least breathing problems for whatever reason. Doesn't have to be lung. Pericardial, knock, okay, and friction rub. Okay, and then look at this echo, extremely important. Echocardiogram is diagnostic, shows you what? Pericardial infusion, fluid around the pericardium. That's what pericardial effusion means. So echocardiogram shows you what? Pericardial effusion, which means fluid. Peri means around, cardial, around the heart, fluid around the heart. And pericardiocentesis, when you take the fluid out of the pericardium, what does it show you? It shows a cloudy cirrus means thin, sanguineous fluid, increased protein. So the fluid has protein in it, numerous red blood cells in it, and white blood cells in it. In addition to that, it has neoplastic cells, right? Neoplastic cells, cancer cells, neoplastic cells. So pericardiocentesis, pericardiocentesis. Pericardiocentesis is a procedure through which you take fluid out of the pericardium and you analyze it. What does it show you? It shows you neoplastic cells. Neo means new, plastic means growth. New cells that were produced by mitosis, right? Neoplastic cells. And these neoplastic cells have large nucleoli and mitotic spindles. These are signs of cancer cells. So I'll put it here, cancer cells. Okay, good. Now we can go ahead and answer this question. Okay, if I were to look at this, we have persons experiencing shortness of breath and fatigue, which means the tissue is not getting enough oxygenation, right? The tissue is not getting enough oxygen. There's so many causes where you can have dyspnea, which is shortness of breath, and fatigue. So many causes. Any issue with lung can lead to that. Any issue with heart can lead to that. Any issue with the red blood cells can lead to that. So what is in this case the cause? Well, in this case, it's telling you this person has pericardial knock, friction rub, and echo shows you pericardial effusion. This triad, pericardial knock, friction rub, and pericardial fluid, is 100% pericarditis. I'm not even going to discuss it anymore. Okay, so this is pericarditis. But carditis has so many causes, right? So, or you can say you can, if you don't want to say pericarditis, you can say pericardial effusion. That's good enough, which causes the symptoms, right? But it has so many causes. In this case, the cause seems to be neoplastic. So this is neoplastic pericarditis, neoplastic. Because the fluid around the pericardium are because of the cancer cells, right? Okay, so the triad that I want you to memorize from this question: pericardial knock, friction rub, and pericardial effusion on echocardiogram is done. This is pericarditis. Now, to identify the exact cause, I will change colors. The exact cause of this is neoplastic. Why? Because it's telling you, they're telling you right here that pericardiocentesis fluid shows you cancer cells in the pericardium. Okay, so now we have identified the cause of this person's pericardial effusion is what? Cancer cells. Okay, the next question is, which of the following sites is the most likely origin of these cells? The origin of these cells. So these neoplastic cells come from what area? Which cancer is causing this pericardial effusion? That's what they're asking. Okay, or at least I am asking. To answer this question, let's do this. let's do a drawing. Let's do a drawing. So here is a person. I'm giving this person some hips. Okay, so I guess the lower body is not that important for answering this question, right? Never mind, this was not good. Let's just keep it simple. Let's keep it up to the upper body. I don't want anybody to say something about me. Okay, there you go. So this is the person. Here's the eyes. Here's the mouth, nose. There you go. This is obviously a female. So the chest, breast area. Okay, so now this is what I want to do. Where is the heart located, right? The heart would be located on the left side. Let's say this is the left side. Here, I don't need this anymore. The mirror image. So the heart is located right here. Here is the heart. Okay. So that's the heart. Okay. Now around the heart is the pericardium. So I'm going to use green. So when you look at echo, echo shows you this green line around the heart. Green might not be good because it doesn't indicate. Let's use blue, so to indicate fluid, because we think of water fluid as blue. So here you go. It shows a ring around the heart of fluid. So that's pericardial fluid. That's what you will see on echo. Okay, so this is what you see on echo. Pericardial fluid. There you go. I'll change it to blue. Good. That's what this person is having. We know that the cause of this pericardial fluid is infection, cancer cells. So if you just look at this option, what cancer is most likely? So cancer can travel by two ways, right? Metastasis, metastasis, that's one, and direct invasion. Okay, so direct invasion, that means there's the cancer, it travels directly and invades the next neighboring structure. Or it can travel through blood, metastasis, or through lymphatic. So if it travels through blood or lymph, then it's called metastasis. But if it's directly invades the neighboring structures, then it's called direct invasion. So cancer can go to other tissue by two mechanisms, right? Now, let's look at direct first. Do you think breast cancer is most likely to directly invade this heart or pericardium or ovaries? And ovaries will be located here. Let's look at this. Here is, let's say, the uterus, the birth canal, right? And then the fallopian tubes, and the ovaries are right here. So choice B, ovaries far away. For traveling, it's far away. And for direct invasion, it's far away. So I'm not going to choose ovaries. So far, breast cancer is the best option. Uterus, same thing. Uterus and ovaries will be the same thing. Okay? All right. So at least based on direct invasion and metastasis, I'm not going to choose ovaries and uterus. Cervix is the same thing. This is the cervix area. And cervical cancer will be in young female, not in 55. 55-year-old, you're going to think of breast cancer, number one, ovarian cancer. Again, which ovarian cancer? Epithelial ovarian cancer, not germ cells, right? And not stromal cells. So based on this age, 55-year-old female, I'm going to think ovarian cancer and endometrial cancer or uterine cancer will be most likely in this area. Okay, so this person is unlikely to have cervical cancer anyways. Plus, it's far away. Vagina, same thing, far away. Vulva, which is mostly due to HPV. If it's vulva cancer, it's rare, but it's again far away. It's external, right? It's more like a skin cancer. Skin cancer, far away. Colon cancer, even more. Colon will be right here somewhere, right? Depending ascending, descending colon. So colon cancer. Stomach cancer, yeah, that will be my next choice. Lung cancer will be my first choice. My first choice will be lung cancer. Number 2 will be breast cancer. Number 3 will be stomach cancer. Okay. So based on this information, you should be able to make that choice. Now, knowing that this female is 55-year-old, okay, which puts her at a huge risk of breast and lung cancer. If the question is talking about smoke, then I'll choose lung cancer. But if it's not, then I'm going to stick with breast cancer. So let's see. Her pulse. There's no information regarding smoking. There's no information anything else. Um, it's going to be tough. Um, and plus, if it was lung cancer, remember that on echo you might find some fluid in some mass. So I wish there was chest X-ray shown. This is going to be hard, so I will not choose stomach. I'm between lung and breast cancer. I'll choose breast cancer because breast cancer is very common in female. Okay, um, so that's what I will choose. Breast cancer right here. It's going to directly invade, plus through lymphatic and can travel to the heart as well. So think of lung cancer and breast cancer. Because I'm not giving any history of smoke or anything else to indicate this is lung cancer, I'm going to stick with breast cancer. Okay. Hopefully this answers the questions. Let's choose our choice. The choice was breast cancer A. A should be the answer. Okay. Beside that, if it was breast cancer, age helps you, family history helps you, those things plus um, those would be some things to look for. Okay, let's go to our next question. Okay, so the next question is, a 39-year-old woman comes to the physician because of painful intercourse followed by discharge. Pelvic examination shows a 2 centimeter irregular rough gray-white painless plaque on the cervix. A biopsy specimen of the lesion shows invasive squamous cell carcinoma. Malignant cells from this site will most likely drain first to which of the following lymph node in this patient. Okay, very straightforward questions. This question is anatomical question, simply telling you this person's having cervical cancer. So this cancerous cells from here will metastasize first through which lymph node. That's all they're asking for. But if I were to, so I should know this, how to diagnose cervical cancer. Cervical cancer. What are some things I need? So when I read these questions, immediately I'm thinking, whoa, this is cervical cancer. So that's what I should be. Number one that I look for is reproductive age female. Compared to breast and endometrial cancer, cervical cancer usually in young female. Reproductive age. Okay? And of course, there should be some sort of indication exposure to HPV virus. So reproductive age, HPV, I keep it together. Okay? Number two, when the lesion is large, usually it will cause discomfort, okay? Sexual discomfort, so dyspareunia, which is painful intercourse, okay? Painful intercourse. And three, there is usually discharge, cervical discharge, vaginal discharge. When I have a young reproductive age female, so now the risk factor for HPV will be smoking, hypersexuality, early menarche, late menopause, all those or more, those kind of things. Okay, promiscuity, drinking, polysubstance use, all those things are risk factor for HPV, especially multiple sexual partners. Okay, or you can say sexually active female, or at least having the history, right? So look for those things. So far I said reproductive age, which would be reproductive age, dyspareunia, and discharge. These three, when I find in a patient, cervical discharge, dyspareunia, painful sexual intercourse, and reproductive age, I think of cervical cancer right away. That's my alarm. So I'll think of cervical cancer first. Now, how do I know if it's cervical cancer? I'll do a diagnostic step to confirm it. Okay. Then you can actually physically see on pelvic exam there will be cervical lesion. Okay, so look for a cervical lesion. Because this cancer is caused by HPV, you know that HPV causes lesions that are on the skin that's cauliflower-like lesions, which is gray-white lesion. But on the cervix, it'll be flesh color, like almost like beefy color, right? But it'll be irregular, painless, motionless mass, immobile, painless, rough mass. So look for that. Okay. So, and then if you take a biopsy of that, you find the DNA for HPV, or you find malignant cell. That's it. It's confirmed. Okay. So that's what I want to do first. First, let's diagnose it. If there's cervical cancer, let's look at our question to see if we have this information. A 39-year-old female is female of reproductive age. Okay. Comes to the physician because of painful intercourse, which is dyspareunia. Okay. Followed by discharge. And usually the discharge, yes, by remember, so like when you move the cervix, the cervical os can open up and the discharge can be initiated in that sense. Pelvic examination shows a 2 centimeter irregular, rough, okay, gray-white, painless plaque on the cervix. When you do a biopsy of this plaque, okay, of the cervical lesion, like right here, biopsy shows you invasive squamous cell carcinoma. That's it. It's confirmed. So now that it's confirmed this is cervical cancer, what is our solution? What is our question asking? The question asking malignant cell from the side will most likely travel. Most likely first go to which of the following lymph nodes? Okay, so metastasis to lymph node. Which lymph node it will go first? Okay. To do that, we need to know anatomy, right? We need to know anatomy of these lymph nodes. Okay, let's go with the first one, A. Let me change it to red. A is talking about inferior mesenteric lymph node. If you remember from your anatomy and embryology, inferior mesenteric artery, or the general rule is this. Let me tell you the general rule. The general rule is lymphatics in lymph node always follow an artery. Okay, lymphatic flow or lymph nodes always follow an artery. The name will be usually corresponding to that artery. So lymph nodes that are inferior mesenteric lymph node, they follow or they drain structure that are supplied by inferior mesenteric artery. If you remember that we have celiac trunk, inferior mesenteric, superior mesenteric, and inferior mesenteric artery. Inferior mesenteric artery. Remember that. What structure does it supply? Okay, it supplies hindgut. Hindgut. Celiac trunk supplies foregut. Superior mesenteric artery supplies midgut. Inferior mesenteric artery supplies hindgut structure. What are those structures? Well, hindgut starts from the distal 1/3 of transverse colon all the way to anal canal. So in this case, what does it supply? Most structures of the hindgut, especially, let's say, the latter, okay, the distal 1/3 of transverse colon, plus descending colon. I'm missing a C there, but anyway, so descending colon, all of the descending colon, okay, sigmoid colon, and upper rectum. Okay, let's include here, I'm running out of room, upper rectum. Okay, upper rectum. So starting from the splenic flexure, which is the distal 1/3 transverse colon, going down, the next is descending colon, the next thing is sigmoid colon, and then is rectum. But it only supplies up to the upper half of rectum. So that will be inferior mesenteric artery, which does not include cervix. So I'm going to cross that out. So that's A is not our choice, is not the answer. Okay. Para-aortic lymph node, remember they're also known as lumbar lymph node. Para-aortic means if this is aorta, okay, let me do this. Let's say this is aorta. Aorta gives you the renal arteries, if you remember that, and then it splits to common iliacs. So lymph nodes that are next to the aorta are known as para-aortic. Okay, that's what they're known as, para-aortic lymph node. Lymph node next or parallel to aorta. Para-aortic node. Okay, also known as lumbar lymph node. What do they supply? Obviously, they're going to supply. Remember, in embryology, kidney develops here, ovaries or testes, okay, and then the descent, okay, ovaries, testes, and kidneys, but then the ovary and the testes will slightly descend, and uterus, okay, so that's what it will be. So based on embryology, para-aortic lymph node would be draining ovaries or testes, depending if it's male or female. So you can say gonads, right? Ovaries or testes and kidneys. That's what para-aortic lymph node will drain. If this was kidney cancer, testicular cancer, ovarian cancer, or uterine cancer, then you'll be choose uterus, right? Then you will choose B. But we have cervical cancer, so we're not going to choose that. Remember that cervix is not supplied or drained by para-aortic. It's only the uterus. Cervix is the bottom, the neck of the uterus. Okay, let's go to internal iliac. Next one is internal iliac. Internal iliac will supply lower rectum. Should I change color so you guys can see better? Yeah. Will supply lower rectum. My lips are getting dried. This lecture got prolonged. Lower rectum. After rectum will be anal canal. Okay. But anal canal above the pectinate line. So above the pectinate line. Should I write that? Okay. Above pectinate line. And hopefully you guys know what I'm talking about. One more thing, guys. These questions are comprehensive questions. I expect you guys to have been gone through medicals, the basic sciences already. I expect people who wants to learn from these lectures to have finished the basic sciences. I cannot go to every single detail. It will take forever then, like to describe what is pectinate line, what is this. So I expect you guys to know those basic anatomy. And then it also goes up to middle third of vagina, okay, in female. So that's what this will internal iliac will supply. In addition to that, it will also supply, if it's supply vagina in females, let's say the male counterpart, let's say prostate as well, and vagina plus cervix, okay. All right, so our question is cervical cancer, so our choice should be C, because internal iliac artery is the one that drains cervical cancer. Okay, let's keep going through the rest of our option. Deep inguinal. Okay, the next one is deep inguinal. So you have femoral lymph nodes. Femoral lymph nodes are split or divided into deep and superficial. Okay, so the deep inguinal lymph node, always think of penile cancer. Okay, so usually this one drains glans, penis, or clitoris in female, right? Clitoris, okay. And then the last one is superficial inguinal lymph node, which drain much more structure. Superficial inguinal lymph node, they will drain labia in females, right? So labia majora primarily, the major labia, vulva. Okay, again, superficial structure. Scrotum in men, scrotum. Okay. Anal canal below the pectinate line. So remember that. Anal canal below the pectinate line. Anal canal. Okay. And skin below the umbilicus plus, except with the popliteal fossa, you can. So that's the main things. Therefore, our choices does not include deep and superficial inguinal lymph node, because our question was about cervical cancer. So whatever lymph node drains cervix, That's our option, which is C, internal iliac artery. Okay, so I hope this was helpful, and we can go to the next question. Okay, next question. A 9-year-old girl is brought to the physician by her mother because of recent growth of a lump in her breast. She is at the 60th percentile for height and 60th percentile for weight. Physical examination shows a right breast bud development and a few sparse pubic hairs. The mother asks whether her daughter's development is normal. Which of the following is the most appropriate initial response by the physician? Okay, so this lady brings her daughter, 9-year-old daughter, to the physician. She's concerned because her breasts are growing and there's few sparse pubic hair. She wants to know if this is normal or abnormal. Well, so the issue here is we're talking about puberty, right? Puberty. Okay. So puberty, remember that uh, females above the age 8, at 8 and above, so I say 8 and above, I should say 8 and above, or say, let's say above 7 years, okay, if they start having changes, physical changes, or menses, then that will be considered normal puberty. Precocious puberty, so let's say precocious puberty. What is precocious puberty? Because that's what they're talking about, right? Precocious puberty. If this person's changes are abnormal, then it's precocious puberty. If it's normal, then it's normal puberty. So let's say puberty normal here, or we can change. Let's do it side by side. My apologies. Let me just do side by side. So let's say blue is normal. Coloring usually helps. Somebody suggested I use color, so I'll use color. Normal puberty versus precocious puberty. Precocious puberty. Okay, so that's what we're trying to differentiate. That's what they're asking. A mom brings her 9-year-old and she wants to know, okay, we know that, let's go with precocious puberty. Precocious puberty, the age is important. Age should be usually less than 8 years, 8 to 7, sometimes even like less than 7, so depending who's talking. Okay, so that's one. And precocious puberty. And the normal puberty, age is usually greater or equal to 8. Okay, let's just say greater for our simplicity, because nobody will give you like exactly 8.1. So let's just say greater than 8. Okay, now what are the stages of puberty? Okay, the first stage of puberty, normal puberty, is thelarchy. Thelarchy, that's the first stage. Stage number 2, pubarchy. Okay, I'm just giving rough information. And then third is menarche. Okay, menarche is menses or bleeding. Menses or bleeding. Menstrual bleeding, right? So that occurs third. Pubarchy is pubic hair growth, right? Pubic hair. Growth of pubic hair, which occurs second. First occurs breast growth. Breast growth. Now, it might be difficult for some people to like, how would I remember this order? You can remember it alphabetically. That's one way. M, P, T, right? So T comes first, then P, then M. It's reversal of the alphabet, right? But it's in order nonetheless, right? Thelarchy, T first, then P, then M. Know that menses occurs last. So that would be one way to so you can remember. But next thing is you like, okay, menarche menses is easy. I can appreciate that. Pubarche and pubic hair, I can understand that. Thelarche breast doesn't make sense. Well, then you can think of T as thelarche, T for titties. Excuse my language for those of you who don't like that type of language, but you wanna get your license, you wanna become a physician. It's okay to use any kind of language you want. So that's how I would remember it. Okay, now let's go to our question. In this case, this patient is 9 year old. If it's 9 year old, that means I'm thinking of normal growth. Next thing, brought to the physician because of mother recent growth lump in her breast. Okay, so this is, she's 9 years old and she's going under thelarche, right? Her breast is growing. Her growth is normal in terms of height and weight. Physical examination shows right breast bud. Okay, a few spars here. So there's some development of pubarche as well. The mother asked whether her daughter's development is normal. Yeah, it is normal, of course. This is normal. Straightforward question. So let's see. Your daughter may have precocious puberty. No, she's not having precocious puberty. She's 9 years old. So no, A is not the option. Okay. Your daughter's development is complete to normal. Yes. Your daughter is likely to begin menstruation soon. Not soon. Usually, the time period. Okay, so let me change my color. The time period between thelarche, pubarche, these two usually can occur much earlier. They occur early first. They occur early and first, and menarche occurs late. Usually about 2 years. 2 years after thelarche and pubarche. So it's not soon. That's not correct. Laboratory studies will help determine your daughter's condition. You don't need laboratory because you know the person is having normal puberty, so you don't need to determine that. If this was a 7 year old, then you can use lab results to help you differentiate between precocious puberty and normal puberty. Okay, your daughter's breast development is not normal for that expected age. Yes, it is. Okay, so that is a normal age. So the option that we will choose would be B. Okay. All right. So hopefully this was helpful. You should know that. And if they ask you about hormone, what hormone is responsible for thelarche, you can use, for example, thelarche is also known as gonadodarche. So estrogen from gonads, from ovaries. For pubic hair, androgens from adrenal gland. For menarche, estrogen from ovaries. Okay. So ovarian hormones are responsible for menses and breast growth, which is estrogen and progesterone to some degree. And but for pubarche, it's androgen from adrenal gland. Okay. All right. Let's go to our next question. Okay. So this question: a 21-year-old woman comes to the physician because of a 2-day history of painful genital lesions. Physical examination shows painful erythematous vesicular lesions on the vulva, vaginal vault, vaginal vault, and on the cervix. Zang smear of the scraping of the base of unroofed vesicle is shown. Which of the following is the most likely diagnosis? Okay, this picture shows you a multinuclear, a cell that has multi-lobe nuclei. So you can look at it that way. In addition to that, so let's just look at these things. What do we have here? We have painful genital lesion, right? So genital lesions are painful, and this is young woman, painful genital lesions. So the lesions are painful, again painful. They're red, and they're vesicular lesions. Okay, vesicles. Where do you find them? On vulva, vagina, and cervix. Okay, so this is most likely STD. Zang smear, you guys should know what that is. Usually, Zang smear is used for herpes virus or all double-stranded DNA viruses. The herpes family is the major one, which includes about 6 viruses. Shows you this unroofed vesicle is shown. Okay, so this is a Zang smear. Just based on that, I'm going to choose genital herpes. Very simple question, but let's just choose genital herpes anyways, because I don't think anything else. Candida, nope. Condyloma acuminata, which is HPV. Condyloma lata, which will be syphilis. And then what else do we have? Trichomonas. Okay. All right, let me think how I'm going to help you understand this question. Although this question is about genital lesions, so let's just do this. There's two things here in this. The answer choices will guide me this way. Based on the answer choices, I want to. They're giving you genital lesion, okay, or let's say genital lesions. I want to compare genital lesion versus vaginitis, because some options like trichomonas does not necessarily cause genital lesion; it mostly cause vaginitis. Okay, so let's compare these two. From these choices, from these choices that are given to us, Candida causes vaginitis. Candida causes vaginitis. Trichomona causes vaginitis. Tricho, Trichomonas. Okay, so these two will cause vaginitis. The question is not about vaginitis; it's vulvar lesions. So I'm not even going to choose those two. So right away, I'll cross them out. But if these were the choices, what would I expect? Candida is a fungus. Candida is a fungus. Okay. um, and this fungus causes vaginal discharge. Infection of a vagina due to fungus will be vaginal discharge. And what do we expect in this discharge? Now, I'm only talking about discharge because Candida can use glucose and other carbohydrates to metabolize. It can cause lactic acid production and so forth. So pH will decrease. pH of the discharge will be less than 5. It will decrease. That's one. And the discharge will be cottage cheese like white. The discharge will be white, thick, clingy. Okay, it usually sticks to the wall of vagina, just like cottage cheese like. So I'll just put here cottage cheese like. Some of you might start hating cheese, but anyways, I'll use any tools to succeed in life. So if that's what we have to help us memorize, let's do it. Okay. So that would be for fungus. Okay. So again, Candida is a fungus. The discharge that is caused because of vaginitis caused by Candida vaginitis will have discharge, which pH is low and it's more acidic, and the discharge itself is thick, white, cottage cheese-like, and clingy. Okay. All right. If I do wet mount test of the discharge. If I take this discharge and I do a test of it, okay, and then I treat that discharge with KOH in parentheses or brackets, KOH, what would I see? I would see pseudohyphae. Pseudohyphae. You should memorize that. It's high yield information. Okay, and if I were to treat it, I'll use miconazole. Anyway, so that's for Candida, right? Now let's go, let me change color. Let's go to Trichomonas. Trichomonas is not a bacteria, it's not a virus, and it's not a fungus, it's protozoa. Protozoa. Okay, protozoa are motile, right? So that's number one thing. Whereas Candida, remember, Candida is a fungus, it's a yeast. So you'll be looking for yeast and pseudohyphae, but for protozoa, it's motile. So you'll be looking for a motile organism, single cell organism. Protozoa means single cells, metazoa means multiple cells. They're both parasites, right? So motile, flagellated, flagellated, sorry, flagellated, flagellated organism. Okay, how many flagellas? 4 flagella in one nucleus. So they will have 4 flagella, one nucleus, if you were to see that under microscope, right? And lemon-shaped organism. Okay, so lemon-shaped organism. When you see that, so what Trichomonas looks something like this. And it will have a single nucleus and 4 flagellas. So that's Trichomonas. Okay. All right. So what do you see in Trichomonas? It causes cervicitis. Okay. So again, we're looking for discharge, right? Because it's vaginitis, always think for discharge. The discharge in this case will be green, I think my battery is about to die, so I'll have to stop this. The discharge is green. Let me pause this. Let me grab a charger, guys. Give me a second. Okay, so I grabbed the charger. I'm in the hospital, so I had to go all the way 8 floors down to my car in the trunk. I left the charger there, came back up running. So I'm a little bit short of breath. I promise you it's not a disease. This shortness of breath is exercise induced. Okay, let's go about the discharge. Discharge caused by protozoa or trichomonas in this case is usually green, frothy, malodorous. Okay, and you should memorize these because it will really help you to diagnose and identify these types of vaginitis. And say bad odor, let's just say odorous. Okay, so that's 3 things. And pH, of course, will be normal because it doesn't really, pH will be greater than 5. So look for these things. And when you look at the cervix in both cases, I should have told you that in Candida as well. So you look for discharge plus you examine cervix to see if it's inflamed. Yes, cervix will be inflamed. It will be itchy. Okay, there might be dyspareunia, redness, and pruritus. So just know that cervix will be itchy. There'll be dyspareunia, so discomfort on sexual intercourse, and redness. Okay, so dyspareunia. You guys can do the rest. Same thing with cervix in Candida. In Candida, also the cervix will be inflamed. So cervical inflammation, cervix inflamed. Signs of inflammation will be redness, dyspareunia, and itchiness, right? So look for those things. Of course, for protozoa, the best medication will be metronidazole. But if you were to do a wet mount test, you look under microscope, you will see a flagellated motile organism with 4 flagellas and 1 nucleus. Okay, so you will see that. Now, the question was never about discharge, right? The question is more about genital lesions. So I'm going to cross those out. I just did it for you. Let's go on, move to our real question now. The genital lesion, in this case, we have 3, herpes, and then we have condyloma acuminata and condyloma lata. Okay, let's do those. Let's go with genital herpes. First, genital herpes. Okay, you know the genital herpes primarily caused by human simplex virus 2, herpes simplex virus 2. Could be caused by one as well. So this is a viral, not a fungus. So let's say this is a virus, not a fungus or not protozoa. And then you will have the lesions, right? Lesions will be vesicular, full of clear fluid. So vesicular, full of clear fluid, and the lesions are painful. Okay, lesions are painful. You would also expect lymphadenopathy, so inguinal lymph node, inguinal node enlargement and tenderness. Okay, so inguinal nodes will be tender and inflamed. Okay, expect fever as well sometimes. Expect pruritus. Okay, and you could have discharge, but it's rare. I'm going to put a star because discharge, it's possible, but it's not that common. Okay, discharge is rare. The test that you will do to identify herpes virus infection, you can use PCR, which you can take the DNA or RNA of the virus. This is DNA virus. You can do DNA PCR, or you can do Zank smear, right? Now, Zank smear will show you multinucleate giant cells. Multinucleated giant cells. And if you do PCR, it will show you double-stranded DNA virus. So herpes virus is what? Herpes virus is double-stranded enveloped DNA virus. Okay, so it's enveloped, number one. This virus has envelope, so it's enveloped virus. Okay. Second, it is double-stranded. Its DNA is double-stranded DNA, which is linear. So linear double-stranded DNA. That's the two things that will help you identify it. But on the image, look at this image, we see multinucleate giants, well, multinuclei. You see that like one. Let me see, change color so you can see. Maybe red will be better. One. Let's see, green. 1, 2, 3, 4, 5, 6, 7, 8, 9 nuclei, right? So that's typical of herpes virus. Okay, let's move on to what color is left. Can I use, let me see. Let's choose pink. Okay, so the next one is, so with the genital, let's do condyloma acuminata. Okay, let's do genital warts. Genital warts. It's also infection. It's also viral. It's caused by HPV, human papillomavirus. Human papillomavirus is, again, I don't have room, so I'm going to tell you, you guys memorize it. It's also double-stranded DNA, but the difference is, let me just write it down. I don't know why I do that. It's also double-stranded DNA virus, but the DNA is not linear, it's circular. So this genome is circular, and it's non-envelope. Non-envelope. So immediately you will know how to differentiate it between herpes and HPV. HPV is, so herpes virus and HPV virus are both double-stranded DNA viruses. HPV is circular, whereas herpes is linear. HPV is non-envelope, and herpes is envelope. Immediately you know the difference, okay, when you do the PCR. But the lesions of HPV are, most people have seen it. They will look like cauliflower-like, gray-white, right? Painless, gray-white, gray and white. But remember, they're painless compared to herpes, which was painful. Painless, okay? And sometimes these lesions are friable. When you scrape them off, they can come off easily. There's itching, pruritus, not that much, okay? But there's never lymph node. No lymph node involved. I'll just put nodes. No inguinal lymph nodes are involved, okay? How do you treat it? Well, you can do cryotherapy, laser therapy, remove them, burn them. You can do those things, okay? All right, let's go to the last one, which is condylomata, which is, again, syphilis. Syphilis is caused by a bacteria. The name of the bacteria is Treponema pallidum. Okay. Treponema pallidum is a spirochete. Spirochete. Okay. So the shape is something like this. That's a spirochete. Okay. Syphilis, there is different types of syphilis. Remember, there's primary, secondary, tertiary. When it comes to genital lesion, it's usually primary. Okay, so primary syphilis will be painless ulcer. Painless ulcer. Painless ulcer makes life much easier. Okay. There is lymph node. Yes, the node's involvement is also painless. So nodes will be enlarged, but they're painless, unlike in herpes, right? Okay. Secondary syphilis will include like systemic signs, maybe arthritis, fever, rash. Okay, and then it can become tertiary syphilis years later. It can lead to aortitis, and it can also cause neurological neurosyphilis, which is dorsal column damage or degeneration. Okay, those are later on, but maybe I'll tell you quickly. You guys can write it down. I don't have room, and my hands is getting tired. So secondary syphilis will be systemic signs such as fever, weight loss, arthritis, rash. Okay, and the rash is usually red rash, macular rash. Tertiary syphilis is neurosyphilis or tabes dorsalis. Neurosyphilis involves the dorsal column of spinal cord. So spinal cord degeneration, especially the dorsal column, is responsible for proprioception, touch, fine touch. Okay, It's primarily sensory. Position vibration, that's one. Sensory touch, which kind of touch? Fine touch. And proprioception, discriminating between 2 points. So those will be, you will have, the person will be unable to sense their position in space. They'll be unable to sense vibration. Let's say a train is going by, you won't feel it. And they will not be able to discriminate between 2 points. Like if I were to put two pens and touch your palm of your hand, you will not know like where the two touches are from. So fine touch, okay? So that's position vibration, fine touch, and proprioception. Loss will be due to syphilis, neurosyphilis. Aortitis, it can cause aortic aneurysm, okay, or aortic dissection. So that's for syphilis. That's tertiary syphilis. And for tertiary syphilis, if I were to diagnose, sorry, for primary syphilis, if I were to diagnose if the bacteria is still there, I can use dark field microscopy. Dark field microscopy. What is dark field microscopy? If this is petri dish, let me make it dark. This is petri dish, and then I want to see if there is any spirochetes. I will see motile spirochetes like this. Okay,